We have been gifted a voice and a position in society which many people do listen to. And I think we need to use that voice, not just siloed in this office space or in this hospital bed, or in this operating room, but we need to go outside of that. And we need to penetrate into administration. We need to penetrate into politics. We need to build community with underserved people, not just when we're looking at them in the office, but outside of the office. Like the farm workers need to know we care about them, not in the office because we're treating them for a medical condition. They need to know that we stand behind them.
Welcome to the Too Curious MD podcast. I'm Dr. Ali Ahmed.
And I'm Dr. Soraya Khan.
In this podcast, we are asking the unasked questions.
We're physicians applying the lens of narrative medicine, exploring integrative practices and psychedelic treatment in healthcare.
Together with our guests, we weave new learnings from stories, expertise, and the sciences. Let's dive in.
Welcome to the Too Curious MDs podcast. Today we have Dr. Farah Karipineni, MD, MPH, and Fellow of the American College of Surgeons, who's a highly accomplished endocrine and general surgeon based in Fresno, California. In your current role, you are an associate clinical professor at UCSF Fresno, and you also practice in the community in Fresno, California. We have a little bit of overlap there where you did your general surgery residency in New York at Albert Einstein. I actually went to my own residency there. And you blend all of this training that you have with also this work that you do in advocacy. So endocrine surgeon, public health advocate, and storyteller. And you're also the only endocrine surgeon serving California Central Valley. Is that correct?
Yeah, except for I have a partner now. Our former resident who did her fellowship, she came back and joined me. So now we're two.
Congratulations. Well, that is beautiful. And this is important because California's Central Valley is where 2/3 of residents rely on Medi-Cal, which is California's state Medicaid. And as we know, that's been in the news. So as coverage shrinks and access erodes, you're bearing witness to a system in crisis. So right now, it feels really, really current and important to speak to these stories that we're witnessing happening amongst us. And I think they're happening at such a rate that it's important to really bring them up, speak for those who can't speak for themselves. And I really admire work that you're doing in this. Yeah, you're welcome. Thank you for being here today.
Thank you for
Alia?
having
Oh, thanks.
Thank you, Farah, for being here. You are such an advocate and a writer and a mother and an excellent surgeon. And I would have to add that endocrine surgery, the first time I ever heard of it was when you told me about it. And I was like, oh, there's a specialty in endocrine surgery, and the nuance and the delicacy with which the surgery is, provided is quite intense, and the stories you've told me about them have been really riveting. And I think I'm glad to have you here today. We're going to talk about some of the healthcare issues that we're confronted with these days, and that is the most beautiful bill. And this is the very play on words, and it's a way of really marketing, I would say, something that could be really, really impactful and also affect the healthcare of so many people who may lose coverage. And I want to really highlight the importance of discussing these things among physicians, among people who are definitely going to be impacted, for the patients that we see. And can you tell us a little bit about what the most beautiful whatever bill means to you, and why this idea of a beautiful bill even matters? Like, tell us more.
Yeah, so first of all, thank you so much for, having me on. It's always such a blessing to be here with you guys. And I really admire all the work that you guys are doing in the integrative medicine. And it's really a space that is so unique, what you guys are doing. So thank you for all that you do. And thank you for having me. I think this is a very timely thing to talk about. things before the big beautiful bill were not going great for Medi-Cal patients, and for the underserved in general. And so this is going to be a huge hit. And I think it's a good idea for us to talk about it. I'm not bringing to this discussion any specific political background that I have. It's more in the capacity of my lived experience as a subspecialty surgeon, a practitioner in an underserved area, having seen what the struggles are already and seeing what we're going to inherit as further struggles. And this, mind you, is off the heels of COVID, from which we never recovered. As far as healthcare, and those of us who worked in the trenches during that time and afterwards will know exactly what I'm talking about. So it is an interesting time, and there will be interesting challenges. And so what it means to me, one of the biggest things out of all of the things that were rolled out with the big beautiful bill, and for us to talk about as physicians, are the Medicaid cuts. I think that's one of the most glaring things, because the Medicaid funding was already very, very much in contention. Once the Affordable Care Act was passed, immediately thereafter, it has been under scrutiny, and people have tried to bring it down since the beginning by reducing the funding, by getting rid of it entirely. And so there currently isn't much to take from that program without just completely slashing enrollment. Which basically, some people, as far as the Congressional Budget Office, analyzing the effect, has said that potentially 7.8 million people will become uninsured. Which this Congressional Budget Office is nonpartisan. And of course, this somehow becomes a very partisan issue. None of this is partisan. This is just about people getting health care. And we are doctors, we are nonpartisan, and people should get health care, otherwise they will die. And the other people who need health care will also die because the other people are flooding the emergency rooms. So I think that's something that everyone should also understand, even if you don't particularly care about Medicaid patients or the underserved.
Absolutely. This when you're talking about public health, the health of the public matters to the individual. And here right now, we're kind of everything is being looked at from a lens that actually doesn't even understand anymore what the health of the public means to the individual. You just said, if you slash Medicaid for a certain group of people and those people lose insurance, how does that snowball and impact everybody else in a society? And how, what are some of those aspects that we will start to see happening? There's the crisis place, there's the place of crisis, and the temperature is going to go up there. We know that for a fact. The people who are already underwater are going to be even more underwater. The hospitals are in crisis, the ERs, you talk about placement, you talk about, all the kind of like resonances of the crisis that's happening and how it impacts everybody. I think we haven't thought through that, and I think there's this kind of almost like a lack of empathy happening because of the partisanship.
Mm-hmm.
What do you find is within, I think we have to, as physicians, always say, well, before I even look at a problem or try to solve the problem, what is this problem inviting me to do in myself? Where do I find myself not up to solving this problem yet? Is, I think, a place to start from, because I feel like with the tools that we've had, that we've been employing for the last couple of decades of our lives, we are still in a place where humanity and medicine is in even deeper crisis. And you said this in one of your articles, humanity and medicine is in crisis. And we're kind of in like, whoa, that has come true. So in some ways I'm kind of asking you, what does that feel like to have been in this field for so long, with the perspective you've had, starting from where you are, kind of grounded in the Central Valley, and now looking at this scale of what's about to happen and all the ramifications? How do you in yourself start to reconcile the gap, that
Yeah.
is just kind of like,
Yeah, I think we need to be fierce community advocates. I think it's no longer the situation of, decades and generations prior where, the physician was, you know, we were always going to have to be community advocates, but more politically so, I would say. It's not just going to work and coming home. We have been gifted a voice and a position in society which many people do listen to. And I think we need to use that voice, not just siloed in this office space or in this hospital bed, or in this operating room, but we need to go outside of that. We need to penetrate into administration. We need to penetrate into politics. We need to build community with underserved people, not just when we're looking at them in the office, but outside of the office. Like the farm workers need to know we care about them, not in the office because, we're treating them for a medical condition. They need to know that we stand behind them. They need to know that if you are going to go on strike right now, so that you can send a message that the grapes are going to go bad because you're not going to pick them, they need to know that I'm going to give you some money so that you can stay at home, so that you can strike, that I, as a physician, care about that. And not just about your thyroid condition when you come to my office for like a reimbursable visit.
Yeah. And I'm being reminded also that what's happening in the body, in the person's body, is happening in the greater body of the community, right? Like that endocrine problem is actually a community problem because chances are there's air, water quality involved, there's toxins involved, or some sort of stressors involved that do impact not just the individual, but the community. So I'm always reminded that our work is political because the body is political, and
Very
what
true.
happens to the body is political.
Yeah, I think we should all read Rupa Maria's Inflamed. I think that's a nice blueprint for like just the colonization, the capitalism of medicine, how it has led to inflammation on many different levels. And she puts it really, really well. And I think that should be like required reading. Because like what you're speaking to is inflammation. And just like our bodies have inflammation, it leads to different kinds of diseases. I think there's an inflammation on a social, political level that has led to widespread inflammation of different communities, like redlining, for instance. So many examples.
Yeah. Can you just walk us through kind of the impact that you envision, I think, with these kind of reductions, both in Medicaid, both in the impact that it makes on the Affordable Care Act, and for the expiration of a lot of these tax benefits that were seen before that will be impacted by this bill? What kind of impact do you envision this loss of insurance or Medicaid coverage, or even those tax benefits for people who need them, um, having on you and in the care that you provide for the underserved in Fresno?
Well, I think there's so many things that could happen. We recently had one of our hospitals shut down in Madera. And when that happened, which is something that could happen if there's no funding from Medicaid, that is rural hospitals will be in a lot of trouble. And as they start to have less funding, because they have so many Medicaid patients, um, those patients will have to travel farther into areas that are these larger cities where people are not expecting there to be this overcrowding of really sick patients who don't have any insurance. There's just going to be more of that. So, and in the emergency room, it's still kind of like an equalizer. The emergency room is not this capitalist thing where you can slip someone $20 and then your heart attack means more than that person's brain bleed. It's not like that, guys. So, you're going to go to the ER. There's going to be a lot of sick people there. Why? Because they had to pay their rent instead of buying their insulin, guys. Like that's why. Okay. And then so you're not, no matter how rich you are going to need that emergency room to get your stroke protocol or your heart attack taken care of fast, and there's a window for that. And if you don't get the window, then you could die. And that's you, not the Medicaid patient. But it's everybody really, right? Everybody's going to suffer. So I feel like that's going to happen more often. Already at CRMC, we see, and I think we've talked about this before, how The hallways were actual hallways before COVID. And then in COVID, the hallways became units. And now the hallway to the hallway on either side is also a unit of patients, and it's literally like reshaped how you walk into the hospital because it's not a hallway anymore. It's an actual unit for patients. And that we never recovered. And I shuddered to think what's going to happen next. Like, where else could you put a patient? And
Yeah.
we started having discharge lounges, and patients are, the minute they can be discharged, we're like, you got to discharge the patient. It's become like a quality measure. And it's always been a quality measure because you always have to get patients in and out. But now you can't, there's no space for that patient to even like get their discharge instructions and change their clothes. You immediately get them out of the room so that someone can get out of the ER so the next patient can get into the ER. And that's just going to get a lot worse. And so, in the most simplest of terms, uh, it's going to be really hard for life-saving care. Now, the other thing that's going to happen is that all those outpatient, what's going to happen on the outpatient level? So I'm thinking as a subspecialty surgeon. So if you can't get your surgery done, this happened in Madera, and I'm thinking it's gonna happen more and more. If you are not Medicaid, let's say you have great insurance, but you had your surgery scheduled at Madera Hospital with another surgeon, a gallbladder or a thyroid, whatever. Now, Madera shuts down, you can't have your surgery there. You have to establish care with someone else who actually has privileges at a hospital that's open. So then you come to me to get your gallbladder done. Well, now I have lots more consults before than I had before, and my wait time is a lot longer. So you are not going to be able to get your care as locally as you could otherwise. So then you're going to go somewhere else, hoping that you're going to get better care there. Those places, we are at the point where they're already at Stanford, 1 in 3 people in the ER is quoted to be a Medicaid patient. So they're already seeing the overcrowding effects as well. So there's no guarantee now that you go to that, higher level of care, that you're going to actually get yourself your timely gallbladder either.
Wow.
Absolutely.
Yeah, I mean, it's not that. I remember the first time I walking through CRMC and Fresno and seeing over 200 people waiting for beds, and that was a shock to me. I was very shocked coming overseas, where I was practicing global health and came back to America after 10 years, and I walked through that ER and I go, "What happened to America? What happened to the emergency room?" And then when COVID happened, of course, the impact continues to get worse, and we're continuing to talk about the same problem and the same issue. And yet, what is going on? Why aren't doctors, why aren't people in the healthcare space speaking about this or rising to the surface on the issues here? What do you think is needed to really move this in a direction where people can listen and understand the consequence of this?
I think we need more physicians in these positions to make these votes. I think that physicians need to get political. We need to back physicians who are willing to make their jobs political. In South Carolina, there's a doctor, I'm going to try to find her name, that's running, and she's on social media, and she's really great. She's out there trying to challenge Lindsey Graham, and Annie Andrews. She's running to defeat Lindsey Graham, and she's a mom of 3. She's a pediatrician, and she speaks out on these issues a lot. And I think she's not a career politician. She's a pediatrician. And she's been in activism like Moms Demand Action, been on, Instagram making reels about this bill that we're talking about now. And she is just laser focused. And I think we need people like that. And not everybody's going to be that. We don't all have to reinvent the wheel. We can identify people like that and focus on supporting them. So it takes all kinds, and we're not all going to be the ones to jump into politics. There's also local politics. There's a lot of money, for instance, right now, locally in Fresno County that hasn't been used, that's specifically earmarked for the homeless. Now, what are they going to do with that money? We don't even know. I'm sitting here, I don't even know about that money, right? But I know about it because of a local advocate who I work with on her organization called We Are Not Invisible. And so she knows that there's this money because has time to go to these meetings. And so we as physicians don't have to reinvent the wheel. Sometimes we just have to identify people in the community and then show up. So how do I know about this? Because she asked for a meeting with me. How did she ask for a meeting with me? Because she knows I care, because I've showed up to a bunch of things. And so, and that was a privilege actually, that she, felt that it was worth it to speak to me about the things that she has on her mind about the homeless community. And I think building relationships like that, it takes time. Um, it takes a lot of time to do. But once those relationships are there, they can't be broken. It's really, really powerful. I think we should do more of that.
I have a question. I really believe in this, and I feel like we're almost looking at it from the lens of, are we talking about redefining the role of a physician in society? Almost like, are we at that moment? Right? Like we have, Farah, you and I think we have parents who are physicians, right? So we kind of grew up with that. And there was always this way that a physician was. And that's how we're taught behind a professional kind of, you know, um, facade. Because I feel like there's still almost a generational difference between how physicians almost look at themselves in society right now, to my parents' generation, the boomer generation of physicians. This kind of public advocacy would be like, oh no, right? Like, don't even. I don't know if that's true for you, but at least that's and now us as, I don't know what it is about the pediatricians wanting to like step in and save everything.
I love
That
it.
must be a thing, right?
I love it.
And then we're seeing like, okay, what do we then look at the next generation? And I'm seeing my residents who are, yeah, they're on social media. I see some of them really looking to the task of crafting the narrative. We have the Dr. Glom Flocken, I think that's his name. He's on social media talking about how even just some of these things, how funding and reimbursement and everything does impact, and doing that in a really lighthearted way. But how do you think, so this is my question, how do you think we can redesign medical education? Because we've been redesigning medical education, but I think we've been redesigning it for efficiency
Mm-hmm.
and for billing and coding. And I feel like we've really let down our current cohort of medical students, because we've even squeezed their preclinical time to almost 18 months. And yes, we've dropped them into the clinical space, but then in the clinical space, they're learning from a different perspective. And I feel like, part of what drew me to medical education was when we would talk about the medical humanities, we would talk about social justice. Actually, one of the courses I taught at USC had the Rupa Maria's book, Inflamed,
Cool.
as their summer reading. Yeah. And it blew the lid open though, because these are such dangerous topics to be talking about in a class full of, right? Like I had 24 students, and there was so much disagreement about the realities that they perceive, because some are coming from Indiana and some are coming from California, Central Coast, some are coming from, Irvine, and they're all kind of getting together in the same room, and they're all reading about the healthcare system from this other lens that they may never have encountered. The stories of other people in healthcare that, complexify what a medical student's choices. So how would you redesign medical education to better prepare doctors for what's going to happen?
Yeah, that's a good question. I think modeling is really important. Everyone has a different technique with, how they interact with residents. Some are more hands-on, some are more hands-off. I personally, as a learner, learn from watching a lot more, and then from once someone's interested in something, from like them asking questions and expounding. But I try, as in my professorship role, to model more than directly tell. And everybody who works with me, like my whole like scrub tech staff, like my outpatient office staff, knows about my stances on literally everything when it comes to social justice. And so sometimes it's just like having these conversations in their earshot as we're doing surgery, or as we're advocating for a Medicaid patient or something like that. But I think modeling is super important. So I try to share what I'm doing, um, not necessarily because I'm like, you should do this too, but just to show them what it would look like. And I think that's really important is because I don't think it's that they don't want to do it. I think it's overwhelming. I think a lot of us get overwhelmed too. I gave a grand rounds on compassion, Compassionomics. I don't know if you guys have read that book, but it's a good one too. And one of the feedbacks was, we already do so much. You want us to do this too? And it's hard. It's a lot, right? So when you say that, about like how, we have to redefine our role, it is overwhelming for a lot of people who already are struggling. And we all see our struggles differently. We all have different financial struggles. Some physicians are really struggling financially. Primary care doesn't pay well. And you might not be married to someone who's working. You might be the breadwinner. So I get it. There's a lot going on. But compassion is actually financially, um, it's a financially feasible model. And so is keeping Medicaid, by the way, And so sometimes you have to use people's language in order to speak with them. And so when it comes to,
Yeah.
to to demonstrating the importance of doing this to colleagues and to trainees, we might have to make an argument like that, with compassion, and with being part of the community, all of these outreach things. For me, it gives me so much. And so that's an argument that I make. I make sure to demonstrate how much it has enriched my life. Um, and uh, and I always invite people to come with me, like try to invite them to certain things that I do. And not all of them, I say most of them actually don't take that invitation, as far as the residents, because I work with surgery residents. Also work with students. A lot of the students will be very receptive to that. And we've had book clubs, we've had outreach with them, a lot of things. They have more time and the surgery residents don't. So the most that I can hope for is that I have modeled something of what it is to be a voice in the community, to build community, to be a voice for health disparities. And I also, as my residents know from how messy my office is on when my kids are there, and how to be a mom, as well, and just kind of like bring all the parts of yourself to where you go, because as people remind you, there's a lot going on. How am I going to do it all?
Yeah. I love how you bring in all the elements of who you are, your identity, your work, your role as a mother, your role and as a writer and as a person who represents and models. That's such an important role. All aspects of what you, as a surgeon, standing there in the middle of cases all day long. Sometimes, the cases that come in and the complexity of those. I'm also curious about what you talked about earlier. You have an MPH. You mentioned the book Inflamed. We're talking about social justice, and what is not really apparent, I think, to a lot of physicians or to people in the healthcare field is that just prescribing medication is not enough. Just seeing a person and saying, okay, this is going to heal you, that's just not enough, because outside of that space there's so much more happening that is a direct impact of on how people live. And how people live is what happens to their bodies,
Mm-hmm.
right? So if you are impacted by your socioeconomic stressors that you live in, the toxins that you're exposed to, the malnutrition, it's the stress of of survival, and then not having insurance on top of that, where you don't have access and you're blocked. It seeds to so many things. It seeds to all elements of how we live, and that has an impact on everybody, as you mentioned.
Mm-hmm.
So, how can we take this to a broader av- platform? Because this is bigger than just you, me, and us talking about it. This is really scary.
Yeah, and I want to add another part of this, definitely that's really scary, and maybe I can expand on what you just said, is with the creation of this kind of world, right, where so many are going to kind of fall off the very delicate edge that they were already on, right? It's creating a sense of this ability we have to look at certain people as more human than others, or deserving of, rights, of deserving of dignity, right? And that's what's happening in stripping away their basic rights. The system is telling them you don't deserve dignity or respect, or your body to be cared for, and how devastating that is on that level. And however, not just is it devastating to the bodies that it's happening to, but to us, what it does to people witnessing that and that happening is it challenges our own empathy. It challenges the limits of our empathy, right? Like when we're talking about how can a resident, for example, who's training, who's in general surgery, who's so busy, when faced with, oh, what are the other roles in society that you may be called towards, because that too is now part of our wheelhouse, right? Vaccine denialism is not just about the quality of the vaccines; it's about this kind of like war on vaccines that's kind of happened, that's really baseless and has no scientific basis, and we are kind of in the midst of it going, oh my gosh, it's going to, over time, what happens is it erodes our empathy. Of course it does. Situations like this where you've had the 10th patient that day and you're having to discuss with them why they should give the flu vaccine to their child who has asthma because it'll actually help them survive pneumonia this winter. And you've had that for the 10th time, and a part of you just is ready to check out. A part of you is saying this problem is bigger than I am, and that's where the edge of burnout is,
Yeah.
right? And that's what I think these conditions are primed for physicians to kind of get into, because we're so empathic. We see everything. We feel everything. We are also powerful. We know we should be able to do better. And when those things aren't happening, that's where we feel really powerless. That's where the moral injury kind of happens. That's where the giving up and the depersonalization, all of that starts, right?
Yeah.
And so where in that mix, just tell me what you see here, that can lead us to recognizing, to resisting, and seeing that it's a story.
Yeah.
Right? Seeing that it's a deliberately, purposefully created set of conditions for us to lose our empathy. And that is that place where physicians are standing at. And I saw us doing that in COVID. Right.
Yeah.
And COVID is where physician storytelling really took off, because we were really seeing like there's no other way for these stories to get out there unless we tell you what it feels like to sit next to somebody and hold up an iPad while they say goodbye to their loved ones. And we did that, and you were right. At the beginning, you mentioned we haven't even gotten over that.
Yeah.
We haven't even processed that. And here we are, right up against situations like that, where we will be standing at the bedside of somebody whose life would have been saved by more food on their table, insulin, a stable place to live, and just access to the basics, just the basics that we talk about.
And this is not a new problem. Structural violence has been around for decades, and for those who aren't familiar, I'm sure you guys are, structural violence is a form of violence, which some people may not see it that way, but that is what it is, wherein some social structure or social institution causes harm to people by preventing them from meeting basic needs, which we should be calling rights, which the Constitution calls rights, but we're just not, doing that right now. Has roots in colonialism and slavery, things like institutionalized racism, sexism, classism. The medical industrial complex is part of that. We are part of structural violence. And to answer your question, it's two parts. One is to recognize what it is and call it out when we see it, which is a huge thing to do. And then the second part is taking care of ourselves to make sure that we can continue to do that, because it is a heavy call. But it was always a heavy call, because the Hippocratic Oath, which we all took, can I read a part of it? I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. I will prevent disease whenever I can, for prevention is preferable to cure. I will remember that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body, as well as the infirm. This is the modern version. It's the original version. It's a similar vein, but there was a lot about of stuff that like it's just not applicable modern in a modern society. But you know, we signed up for something like this, guys. Like yes, once we said we would do that, we entered into a world of finance and business. It's true. And then we adjusted. We adjusted to that, to the point where all of this kind of fell away because nobody was really doing it. But it's what we signed up for. And not that nobody's really doing it. Some people are doing it. Some people are clinging to this, and other people are disillusioned. And other people just completely forgot it. Or never believed in it to begin with. Maybe one of those things. So, but this is what we all signed up for. We all said it in our white coat ceremony, and I believe it. So it's not that alien. It's just alien because of what the medical industrial complex has turned into, which is just a business where there's a transaction and that's it. But we literally said that we weren't going to turn people's illnesses into the thing we were treating. We were going to treat the people and not the illness. And so I think as far as like how do we do that? How do we continue to do that in this society? Well, I think it's really important to treat each patient as you would your family. That's the first thing. And I think it's harder to do in an employed practice. It's harder to do when there's so many patients, but it's not impossible. So just remember that every moment you're in front of a patient is a moment you can resist, is a moment where you can dissent. And don't take that for granted. It means something. It means something to that patient, and that patient exists in a sphere of how many people care about you, like deeply, probably like a ton, right? So that person is in that sphere, and so you just did something really good. And then I think modeling for the residents, for the next generation coming up, modeling that, being loud. I think that we need to be a little bit louder. Just make these videos, where you talk about these things and flood social media with them, and speak loudly about things. Go to the meeting and speak loudly about it. And then when you don't want to go to the meeting because you can't, then learn to take a break instead of quitting, and then come back to it once you've taken your break. There's no shame in that. I think this is and we're not going to solve it today in this. Nobody has that answer, right? But if all of us did a little bit more, then it would probably lead to something good. And I also think that the system has to implode. Like maybe this is the beginning of the end. Maybe this is the thing we need in order for things to change. Something bad has to happen sometimes for things to change, because because the people in power are just not smart enough to figure it out before something bad happens.
Well, thank you. I think you really brought it up all together. All of the calling it out, what we can do, bigger voices, bigger stances, connection, community, building on what we know with others, emulating that and really modeling that. And I really want to, this was such an important episode to do, and you showing up on a Sunday here on a July 4th weekend, and us really connecting on this very issue that brings us together, I think, in a lot of different ways. I take care of patients, and I don't bill insurance, and every patient, they pay for their service, and we take it seriously. we take care of their care seriously. As a team, every person on our team knows that there's a value with this patient. This patient is valuable. Their experience is valuable. Their conditions can be addressed, and if everybody's seeing it in that way, automatically change starts to happen. Automatically the patient starts to feel better because they feel supported, they feel heard, they
Yeah.
feel seen, and the inflammation tends to go down. You can actually measure that. And sometimes I wonder, is this the placebo effect, in medicine? Because it gets so much better just because you're paying attention to your patient. And if only insurance systems could do this better. That's what it's for. And it's sad to hear that I have insurance and yet I don't find it valuable because it doesn't really cover for many things. It denies you this, and you get a headache, and you try to process that, and it's a daily, trying to get prior authorizations. I mean, who wants to do that? In a busy office, and they know it.
Yeah.
They absolutely know it. They know that they can make it complicated. They can deny. Who's gonna fight? Not many people. And I tell patients, you have rights. You have rights. You can go and talk to your insurance. You can advocate for yourself. You can ask an advocate. You can get coverage for a lot of things, but you have to fight as well. And I remind that that's their responsibility just as much as ours.
True. That's very true. And it's hard. I mean, health literacy is difficult, and calling insurance companies, like I would probably rather not do the thing that was denied for myself as a patient rather than call my insurance company and try to figure it out. I'd have to be dying or something. But I do it all the time for patients. And I think that patients or physicians need to realize that what you just said, which is there are certain things that they will deny, like they won't even look at it. It's just a denial. They're expecting that either you're going to accept it or they're going to have to have an appeal call. So if we understand that as physicians, we have to be ready for that appeal call. We have to be ready to the appeal because no, they didn't even look at it. The answer was always no until a phone call. So I always say yes to those. I always say yes to the appeal. I'm going to appeal. I'm going to appeal and talk to it. And you know what? Honestly, a lot of times it does go through finally. Sometimes it doesn't, but a lot of times it does.
Yeah, but it's a purposeful process, right?
Yeah.
To deny first
Yeah.
and then make somebody appeal, and 20 or 30, 50% of people will appeal. And again, this goes for patients too. I tell patients, read your insurance policy. Know what's in your insurance policy. Learn the language and also fight for yourself as well. And I think as I'm now starting to onboard insurance companies for TMS, I'm recognizing, God, the headache and the pain and the frustration and the fear that you're not going to get paid
Yeah.
for services rendered, and yet you have that responsibility. But it's so important that we really address this on a larger scale. I think to physicians and to patients and to the community at large, that we do have rights. We can advocate for ourselves. We will advocate for ourselves. And yes, we stand together on this. And I think that voice can be heard and shared as we kind of, as you said, call it out more and speak loudly.
And we also don't have to have an insurance-based system. And so like we have to do these things every day to take care of the patient in front of us right now because the policy is not going to change right now. But there has to be some view to, like we said, getting involved in politics a little bit more, and dreaming of a non-insurance based system. Like there's so many countries, the UK, Canada, Sweden, Norway, Denmark. Yes, those happen to have like higher taxes that are helping to fund those, but and of course that's not what we want. But we're going to pay for it one way or another. And as we just said, a lot of people are going to pay for it with their life, which is a lot more expensive than taxes.
Yeah. Yeah. I'm hearing, first I wanted to mention that I think the people who work around you guys get a lot of what you stand for. And I feel like that's part of the role of the physician, as you're talking to residents and physicians who are feeling isolated and helpless. I got a reminder from you that exactly you talking about it in the OR, you making a stance, you, Alia, you saying no, healthcare is a right, and coming from a physician, right? Coming from that place of authority that says, no, that is correct, is so, I think, life-giving to that system around you that holds that to be true. And I think as we're talking about even holding space for what is correct, right? Recognizing that, yeah, that might take 5 more minutes on this phone call, but I'm going to do it because it may make a difference, right? Just taking that chance from a place of, and I'm reminded of the time when I was with my kids, and we'd be at the checkout line, and as I'm walking out of Target, I'd recognize that, oh, I was given too much change, right? And I would tell my kids, all right, we're going back in. We got to give the change back because we're not going to walk away with more money than we're owed. Like those important moments where you kind of connect with the right thing to do and you do the hard thing, or the slightly more difficult thing, or the thing that's a little bit more complicated because it's worth it, to the people in front of you, right? So I'm being, recognizing that, and then looking for those places of, and I'm really hearing also that physicians are starting to find that becoming political, having a stance about housing, clean air, vaccines, healthcare, no guns, all of that is actually going to help. I think it is actually going to help because we have enough data. We have data from firearm, research done. We have data to show exactly what we need to do. So it's not like we don't have the evidence to base good policy on. What we need is this ability to describe how this policy is going to, like you said, impact not just the people who are losing Medicaid, but the people who are going to the emergency room for their stroke. Really bringing those contrasting bits in. And I just want to know for you right now, as we're kind of heading into maybe thinking, kind of moving from this conversation, what gives you hope right now as you're looking at the situation and what's kind of coming up?
Well, for me, my faith and my personality, I'm always a what can we do type of person. And like for me, making that extra phone call is wellness because otherwise I do feel hopeless. And for some people, they'll see that extra phone call, their extra thing they have to do as sucking away from them. For me, I see it as empowering. And for much of what I do, I have no idea if it's going to make a difference because it seems sometimes like what's going on right now, it seems like it's so big that we couldn't possibly overcome it. But if you look at the arc of history, it goes up, it goes down, it has different ebbs and flows, and people have been defeated before. Goliath has been defeated before, and so it's not the first time, and it will happen, in my opinion. I know it'll happen. I don't know if I'll be alive for it, but I know it'll happen. And so I focus on what my job is, and my job is to do my part in my space. And I feel that deeply. What can I do? I can do my part in my space. I can show up to what I can do. So I'm showing up to the things that I'm trying to do, and I know it's not enough, but it's what I can do. And then what I can do actually is enough because it's all I can do. And when it goes down in history that, she cared and she tried, she did something here and there. And so that's it, then I did my part, right? Like I did what I could do. That's it. And I have to be able to say that. I have to be able to say that. So that's what drives me is I'm going to do my part. I'm going to do what I can do. And I used to go on these missions to, Lebanon, to Mexico, and I don't think there's anything wrong with global health or these outreach things, Kenya, Sudan, Uganda. But now, what can I do is right in front of me. Like there's a lot of things right in front of me, and that's where I'm trying to build these roots in this community that I'm in. And it's not an either or. It's just like we said, there's so much going on all the time. But that's what gives me hope is I can do what I can do, and I'm going to do what's in front of me, and I'm going to show up to those things. I'm going to say yes to this meeting. I'm going to say no to that other one. And someone asked me the other day, like, well, why can't you come at 6:30? Can you not come to this meeting? Because it was a robotics meeting, because there's steak being served there. And I was like, no, I love steak. I just can't come to the meeting. It's at 6:30 and it's not about social justice and it's not with my kids. So I'm not going to be there. So that gives me hope, is we can do what we can do, define what you can do, and then do that, do the heck out of that, and then what you can't do, you can't do.
I love that. And I see you doing the things that really have value, that are like really aligned with your values.
Yeah, for me. And I love that for other people
Mhm,
if they have something else going on. But
mhm.
find that thing that drives you, and yeah, and I hope it involves social justice, because it's a really important time for that.
Yeah. I also think it's not devoid of healthcare medical practice, right?
Yes.
It should be kind
Mhm.
of enlisted as a course for all medical students and residents included. They're not excused, to have, because it's so part and parcel of the work that you do. I mean, you can't really ignore it. I mean, social justice has an impact on healthcare, on
Can I
somebody's
talk a
health.
little bit? Yeah, can I also mention that exactly what you just hit the nail on the head is like, by not providing this education as part of medical training, we're actually under preparing our students and our residents in a lot of ways. And that's kind of um, you could look at it as a deliberate omission to, not stir the pot, right? I think, at least from my experience of what happened here in Southern California, was the health justice course was the battleground for the political stuff that was happening in academia over the last couple of years, and it is a really tough, I think, course to teach depending on where your medical school is. I think in Northern California, you guys have a little bit more of an edge, a lot more depth of expertise there, knowledge, and also physicians who really are self-aware. But it was a real hard course to teach, I have to say. And we were kind of looked at as kind of the, oh, you know, um, uh, try not to stir the pot too much. It was actually seen as a bad thing that the medical students were leaving the course kind of really emotionally kind of riled up. And we're like, well, of course you're going to get emotionally riled up if you look at these are just
Mhm.
from reading papers. There was no editorializing. It was really from doing their homework, that you really recognize like a lot of this is pretty disturbing material, when you first come upon it. And I think having mentors, and people who are working in this space and also know how to take care of themselves while working in the space, and giving that as a role model, example as you're doing, is so important, because it's really difficult, when you first encounter these topics.
And I also just kind of chat GBT kind of what things we can do as physicians and patients, and we'll post some of those
Okay.
items that we can in support, or even speak to the professional organizations for physicians, patient advocacy and support organizations are out there. There's also healthcare reform and policy advocacy groups, and we'll post these in the show notes. So please use that list and really, voice your concerns. This is about all of us, and it's about patients, and it's about everybody in between. So
Yeah.
there
And
are
I'd like
ways
to
to get
ask
involved.
Farah, how would people be able to find you and connect with you and the organizations you work with?
We are healthcare workers for social justice on Instagram. It's HCW and then the number 4 and then SJ on Instagram, or Karipineni MD on Instagram. I can also share my email address, if anyone would like, especially if you're in the Central Valley. Any medical society that's your local one. Ours is Fresno Madera Medical Society. There's a board of directors. There's different committees, like the outreach committee that goes to Sacramento for lobbying, and then there's a lot of different stuff too. So and those will be doctors that you work with or like colleagues. So it's also building community, and the same people kind of show up to the same things. Just like when I go to protests or go to like the homeless thing, it's the same group of people showing up to the same stuff. It doesn't matter. It's the headline could be like whatever, anti-racism, or it could be Palestine, or it could be anything. It's the same people. And so, these people are your people, whether, then make community with them, whether physicians or not.
Yeah. Thank you. Thank you, Farah, for being here, and thank you for the work that you're doing. And your voice is powerful, and your experience even speaks a lot, through that in such beautiful ways. And we really appreciate you making time for us in this podcast. And
Always.
we'll continue this conversation ongoing.
Yeah, always. Thank you guys so much. I appreciate it. Every time I get to talk to you guys, I learn something new. I learned something new from all of your podcasts as well. So thank you so much for all the work you do and just who you are and what you stand for. We are richer for all the work that you do.
Thank you.
Oh, it's lovely to be in this with you. Thank you, Farah.
Thanks.
And we keep the curiosity alive. So I'm going to ask you one final question about what would be a curious question you would want for the next podcast.
Curious question. Do I get to participate?
Yes. So we can
we'll
keep
ask
this
Farah.
conversation
Yeah, I was
going.
like, I'll
What would
ask
be a
her
curious
first, and
question?
then I'll have some time to think.
I think what I would ask, I'm actually curious, if you weren't physicians, what would you be?
Oh, that's a good one. I would probably be an activist and a fitness instructor. I'd have
Love
time
that.
for both.
Oh, yeah?
Because let's be honest.
Let's be honest.
I just went to Zumba class this morning, and I realized I used to be a dancer, but now I can't seem to dance as well. But I would be a teacher, and I'd be a teacher, and I definitely would be. I'd love to teach. I'd try to paint and write. That would be I'd like to just continue to do creative works. That would be what I would love to do. I think I could just have a list of things I would do.
You do a lot of things. What about you, Soraya?
Oh my gosh. There's this person I know who actually went on to have this life that's kind of like the fantasy life, which is she's just a gypsy. Her name is Bengali Gypsy. She just travels everywhere, does yoga, and lives out in the outdoors. And I think a part of me recognizes that my biology is so, I've always lived in cities and all of that, but there's a part of me that's just like, yeah, like, we live in the world. Like, I want to live near a body of water. I want to, learn specific skills, whether that's farming or making baskets or, preparing food or something that's more grounded. I think I want to get in my body. So that's the fantasy one. But I think if I didn't do this, I would be a journalist. That was always the curiosity of always telling the stories of people and the ways in which it evolves. But yeah, go live out in the world and leave all of this behind. That's the little fantasy I tell myself.
Yeah.
But thank you. Thank
I
you so
think
much.
for a podcast, I think it would be cool to interview a woman physician, also a mother who has maintained some part of a clinical practice, but has also done something political, like has a political position as well, whether it's like local politics or I guess on a national scale, probably not, but somebody who has like, whether it's city council member or just something, and like what was their path to that, how they balanced everything, and how they've impacted the local politics around them and people's well-being through that role.
Well, I'm going to Google her. I'm going to find her, and we're going to bring her to the podcast.
Dr. Akila Weber.
Oh, there you go. You already know somebody?
I just Googled before she did.
I want Annie Andrews. Can you get her on here?
Yeah.
Yep. There we go. So I said my search was physician mothers in politics.
There you go. Okay.
That's what you asked for. Dr. Akila Weber, Donna Marie Christensen, Kim
Oh, there's a
Schreier,
Mario
lot.
Jill
here.
There's a
Stein, and
lot.
yeah,
Oh, there
yeah,
you go. I don't
Let's get
know.
Rupert Mario on
Oh,
here.
yeah, Rupert Mario would be a good one. Yeah, that would be a great one too. Yeah.
Thank
So
that
you.
would be
exciting.
amazing. That would be amazing. Thank you. Yes, we'll try to make that happen, and that would be a wonderful conversation to have
Yeah, I'll
together.
stay tuned.
Thank you.
Thanks for joining us on the Too Curious MD podcast. We hope today's episode inspired you to ask new questions and explore fresh perspectives. We challenge you to ask us those unasked questions that you're curious about in your medical practice, condition, health, and wellness.
If you enjoyed the podcast, don't forget to subscribe, share it with somebody just as curious, and leave us a review. It helps us keep the curiosity alive. Post or comment with a question or curious inquiry that you have and seek to explore or learn with us. Stay curious, and we'll see you next time.